All right, Jan. So we're just going to go through this case here and just talk about some of the principles Dr. Schipper mentioned on his on the webinar the other night. And I have a case example that I'll show, and then we can talk about some of these things. This is a early 60-year-old female complaining of left foot pain, has a previous history of right foot surgery, and otherwise a healthy individual, pretty active in the community, likes walking, comes in these are the x-rays. So her right foot surgery was, I don't know, 5, 6, 7 years ago, somewhere in that ballpark. And she likes it okay. She did say it was a pretty long recovery, but overall pleased with the result. She gets a little bit of pain in the second metatarsal. You can see there's a little bit of arthritic changes to the second MP joint on that side, but her main complaint is on the left. You know, as I kind of look at this, you think, gosh, that 1-2 intermetatarsal angle is pretty wide, and there's some couple areas that have some degenerative changes. Those are the things that kind of jump out at me. What do you think, Jan? Anything jumping out at you on this X-ray?
Yeah, I agree. It's fairly wide, you know, and I would ask you bring up a good point. You know, she had a prolonged recovery several years ago. Now she's 61. That's not necessarily old, but she's matured a little bit more. I do see on the right side too, which is, I know it's not the side in question, but there's quite a bit of metatarsal shortening relative to the second for the first. Yeah, otherwise I agree. It's a fairly wide angle, not crazy, but definitely more than the right side, which has already been operated on.
Yeah. And she's also getting some pain into her second metatarsal. So I think just bringing up the point of on your exam, taking a look at that, you can see the second metatarsal is a little long. And you can see on the other side that there's some increased, degenerative changes. I think she told me she had a pin in that second toe as well. I don't have any of those records, but you can kind of see it looks like there was something done to the PIP joint also. But so, the other thing is that we've talked a little bit about is the distal metatarsal articular angle, or the DMAA. And, for those of you who do a lot of Lapidus, maybe a little bit less concerned about that, because there's this idea of rotational correction as you rotate. And that's when they talk about a 3-dimensional correction, you're referring to the rotation of the metatarsal. And you look at where it ended up on the right side, and there are questions of whether or not that's a real finding, or if that's just a radiographic finding, just almost an illusion, I guess you might say. What are your thoughts on that, Jan? Do you think that's an illusion? Do you think that's rotation, or maybe a little bit of both?
I think it's a little bit of both. You can see the sesamoids are not perfectly under the metatarsal head. Yeah. And, quick question here, for, some people who are, watching this. How often are you actually drawing out the angles? Are you actually dictating angles that, this is you're just saying, your evaluation of these patients?
Yeah. So in terms of when I draw out the angles, I mean, I don't do it I absolutely on everybody. The ones that I look at though are the 1-2 intermetatarsal angle. And then I'm more likely to look at the DMAA. And I think that there's some validity to it, but it also maybe helps clue me onto some of the rotation. I don't measure out the HVA, the hallux valgus angle, that routinely. But the presence or absence of arthritis, the width of between the first and second, and then looking at the way that the articular surface is pointing, are the things that I tend to look at. And sometimes I will measure those out, or I'll just look at where it's going to sit. If I take the first and I draw that into a reduced position, which ways is the toe going to point? How about you? Are you measuring angles?
No, I mean, I do it sometimes, for the residents, for educational value, because there's still questions sometimes, on the OITE and in-service exam, but otherwise it's more of a gestalt, like that looks wide, that doesn't look wide. Just trying to, figure it out in my head sometimes.
Yeah, I think that you make a good point, and it's hard to keep them all straight. At what angle do you do what, and there's so many different variables to it. This is her lateral X-ray. not maybe a ton to see here, other than the fact that you can see some arthritic changes between the metatarsal and the sesamoid. I think that's worth pointing out because I think sometimes as if you get some metatarsal sesamoid arthritis, that can create some symptoms as well. So as you counsel them preoperatively on your best option, because you could maybe make an argument to think about a first MTP joint arthrodesis in this case as well. Well, so this is what I did, and I ended up electing to use a minimally invasive or a PICA technique that Dr. Schipper talked about. Here's her oblique, but here's the first intraoperative view that I have after I make my osteotomy.
Tell me a little bit how you make your osteotomy. What are your, where, at what level, and what are you doing?
Yeah. So what I'll do is I'll bring in fluoro and I will mark out the level of my osteotomy on my AP view. And I will actually make it, I will mark it out both plantar and dorsal of the metatarsal, because I've had some where if you're not, you can kind of get this, if you're plantar, for example, it can look like it's too proximal. So I'll try to actually mark it out on, put my freer both on the plantar side and the dorsal side on the AP view of the metatarsal, just to make sure that that osteotomy is basically parallel to the metatarsal on that lateral view. That way I don't get fooled into thinking I'm making it's more oblique on the lateral view is what I try to do. So then I'll make sure when they put the x-ray up, and it doesn't show very well here, but I'll make sure that second metatarsal is straight up and down so that I can see that when my osteotomy comes across. And what Oliver talked about, which was really helpful for me, is going relative to that second metatarsal. So because you're taking a couple millimeters off the burr, you probably want to angle that osteotomy about 5 to 10 degrees distal in order to not lose length. So in this case here, I'm probably a little bit angled. I think actually I like the osteotomy. I'm using a freer to actually show the translation in this particular case, but it allows me to gain a little bit of length as I rotate or translate that metatarsal laterally. Is that what you're doing, Jan?
Yeah, and I think that's a key point right there, that you want to try to avoid shortening. You don't want it too oblique, because that can lead to over tightening of the capsule.
Yep. And this one's tough.
Mentioned that.
This one's tough because there's some arthritic changes to that MP joint too. So you don't want to make too much length, because then you're going to kind of jam the joint, so to speak. And so I think it's a fine balance. Now, are you, one thing I didn't do in this case, and I don't do it as routine, is going and work on the medial eminence before. I guess I feel like as it translates, I kind of want to leave that medial capsule intact, because I feel it helps give some rotation and of that capital fragment. What are your thoughts? I mean, maybe that doesn't matter.
Yeah, so I've done it both ways, and I think it's more finicky for me if I do it at first. I like now doing the shift first, and then resecting some of the eminence if necessary, because I found that you don't have to resect as much by waiting, depending on like the anatomy and the shift and the rotation of that capital fragment. So especially if you want to do it minimally invasively, I think I like doing it this way that you mentioned.
Okay, then Jan, one of the things that Oliver talked about was transverse versus chevron. I think we talked that I think we're all doing more transverse as opposed to doing a chevron. That's what you're doing as well.
Yes, I've used to use the chevron before doing this open, like a standard distal osteotomy. But now doing this MIS, I've gone to the transverse osteotomy.
And for those of you listening, if you go to Oliver's lecture, he does a good job of showing why about the advantages. For me, the biggest advantages is it allows me for more rotational of that capital fragment. Okay, so now I've translated it. I got my pins in here, and I actually like that more proximal pin. I'll actually draw this out on my x-ray preoperatively, where I'll draw where I want the head to end up, and then I can see about where I want that starting point. But I think the point is, the more of these that I've done, the more I've realized you really got to get that far proximal into the metatarsal. That's really where you got to be. And then you can abduct the foot to make sure you're not hitting the medial mal. That can be sometimes a area that can get irritated when you're using the drill to put, or the power to put in screws. But this is my lateral. What do you think?
It's tough to tell if this is maybe whether it's flex or just translated. You know, you can definitely accept some more translation than flexion. I liked your AP view in terms of the divergent screws a little bit, just to add a little bit, you know, strength to the construct. But it's tough for me to say here. I think maybe a little bit flex, but not a lot. I don't think.
Yeah, I looked at this and I kind of got to get a couple different views of it, and I definitely felt like it was probably too translate. I liked, again, translated to get that, to take a little bit more of the weight into the first.
Yeah.
But I thought this was too much, and especially because looking at the one wire, it looks good in the proximal segment, but then distal, it looks like it's almost missing into that capital fragment. So I ended up repositioning. So this would be that kind of the next view that I took on the AP, still liking where I'm sitting there. And then this was my lateral, which I liked it better. Yeah. So I think just being aware that, sometimes it's hard to feel when you're getting that piece pushed over, where it is. Jan, do you have any tips or any things you like to do when you're how you translate that capital fragment? I used a hemostat in this case. I've used a pin that I kind of get into like a Steinman pin into the intramedullary canal. They have jigs that Oliver talked about, and you can watch that video to see the different jigs. But what do you think?
Yeah, I've gone through, now most every company has a jig. But when I first initially did that, not the company I was using did not. So I'd use like a joker and move it over and then pin it too. I had no problem sometimes putting a joystick in the head to rotate it. Because just to give me a little bit more control, I could, rotate that capital fragment. You can move it over and then even use that pin sometimes and pin it to the second. It's, especially if I don't have an extra set of hands or something and I'm, first learning out, you're a little bit more critical, I think, of your x-rays and what's going on. And I think that can be helpful, just pinning it so it doesn't move.
Yeah, I totally agree with that. I think that makes a ton of sense. I used to do that on my biplanar chevrons when I would do those open and where I would put a joystick into the capital fragment. And then I was kind of more trying to chase DMAA, to be honest, because I was more of a chevron. But now I think thinking about it from a rotational perspective. And then, there was some questions when we were on the webinar the other night about, this versus a three-dimensional bunion correction. And really, in my mind, and you can correct me if I'm wrong, that three-dimensional part comes from rotating that capital segment. So whether you're doing it at the base of and you're rotating the whole metatarsal, or you're getting some rotational control and a correction of the distal or capital fragment, and as in this case, I still think you're getting that the three-dimensional correction in this situation.
I would agree. I mean, I think it's actually easier sometimes to rotate just the head. I mean, you have a lot more movement distally and you can have a lot more correction because that's the area of the deformity.
Yeah, I agree. So then this was after I got the screws in. The thing I thought was really helpful for me from Oliver's talk was talking about taking 4 or 5 millimeters off of what you measure. That certainly seemed pertinent. I think being careful in this case, I think it was okay. You see my K-wire kind of protruded as I put that screw in a little bit. You probably want to be careful about that if it is in the joint. I think we're far enough off the articular surface that wasn't an issue. Some people like to bring them out into that web space, but he talked about potentially some injury to the cartilage in this case. Now, I came from distal to proximal with my burr to take this resection. I liked his point on coming from plantar to dorsal so you don't injure the nerve. He came through this screw, the most distal screw portal, to take the resection off. So I think whatever you're most comfortable with, I think is reasonable. But I think it's a good idea to resect that overhanging bone And then there was I've seen some mention, and I think he mentioned as well, that you can take that little piece of bone off and you can shove it into the osteotomy site, as others have described. I'll usually just shave it down. Thoughts on that, Jan?
Yeah, I like, it helps you narrow the foot too, because that's going to be
Yeah.
one of the, I guess goals of this surgery is narrowing the foot at times. So I think that it helps you do that. Can you go a little bit about what type of burr you're using? And are you cooling this? How are you preventing any, soft tissue necrosis or bone necrosis during the
Yeah,
case?
so this is a 2 millimeter burr, and that I'm using, and then so it takes about 2 millimeters off. I can't remember the exact length. I think it's 13, but I'd have to fact check that. The in the ideal world, you're using cooled irrigation, and this particular system, you can see it on the construct here, has this little spout that will get some water on there. You can get it flowing pretty well, but I'll still have my assistant irrigating with bulb syringe on the top using cooled irrigation, because if you do get thermal necrosis of the skin or of the bone, I think that can be a really, really big issue. Is that consistent with what you've seen and done?
Yeah, I actually got, after Oliver's talk and everything, I think next time I do this, it's going to be a little bit more aggressive with the cooling.
Yeah.
He brought up some really good points with that. And I think, not just relying potentially on that, the water irrigation here from the burr itself, but, I think that his point is well taken. I mean, you want to make sure you don't develop a non-union or any thermal necrosis of the skin and so forth. So I think it's just a little helpful technique tip there.
Yeah, what I learned the other day was when I talked to the ASC about it. They have to keep cooled irrigation for malignant hyperthermia anyway, so it's not outside the realm of other things that they're doing in an ASC practice to have cooled irrigation. So if you just ask them to have it on hand and looking for the cases, I think most people would be very willing to make that accommodation for you. And then, I think the other thing I think I want to make sure I mention, and occasionally you see some x-rays, this screw here, the most proximal screw, is so important to get outside that lateral cortex. So you're going, through the proximal segment, and then you're actually coming out of out of the cortex, and then coming back into the capital fragment. That is really what provides your stability. And as Oliver pointed out, that now we understand it even better than ever, how critical that is for getting initial stability. So I thought that was a good point. Unless you're using a nail, right?
Yeah, no, that's what I said. I mean, there's so many implants that you could be using here. I mean, I've even seen some things posted now online without even using any hardware at all.
Yeah.
But obviously there's pros and cons no matter what we do.
Yeah.
There's not there's not one size fits all.
Yeah, I think that's right. And then the bailout that I think that is important is realizing that if you needed to, if you can't get it to fit, if you can't get if the screws just don't bite and purchase, you can slip a K-wire, a Simon pin or a K-wire into the intramedullary canal, and that can kind of push that capital fragment over. It maybe doesn't hold it as stable. Maybe you can pin it into the second if you needed to. Certainly when these were early techniques, they were doing a lot of percutaneous fixation with K-wires and whatnot. So it's not outside the realm of acceptable. I think we get so caught up in saying, hey, we have to have hardware in there, and realizing that, shoot, when I was on one of my residency rotation, I still remember using K-wires for bunion corrections and pulling them at 6 weeks. And so I think that's not outside the realm of a reasonable thing to do, especially if you're having trouble with fixation. So I think just keeping that as your bailout.
Agree.
All right. And then this would be my lateral view, always just checking to make sure you got a good lateral view. And then my Aiken, I maybe could have made that a little bit more angled. Angled my osteotomy just a little bit. Sometimes I think it's funny how I get, you think the Aiken's going to be kind of a walk in the park, and then I end up taking more time for that. So the couple of things that I've learned, I didn't do it in this case, but one is I think having a relatively low threshold, you can actually take the K-wire from distal to proximal. So kind of running it, in the same trajectory as I'm doing here, but running it from the web space laterally into the proximal medial segment. So just opposite is a reasonable thing to do. Sometimes that's an easier shot. And then, checking views. These are my finals. And then I did also do a second metatarsal osteotomy and a PIP, but for the purpose of what we were showing, you can see that's my correction. I think my sesamoid reduction looks pretty good.
Yeah, that looks great. I was going to comment on that. Did you specifically rotate it? Were you looking live on fluoro or anything like that when you?
What I did is when I put my hemostat in there, I kind of put that in and then grab the toe with my hand. So I kind of was holding that to translate it. And then I rotated the phalanx at that point. And then I pinned it. But I think your idea of pinning it, if you want to, you can especially if you don't have hands, you can put a K-wire into that capital fragment, adjust your rotation, look at it live under fluoro, and then pin it to the second. I think is very, very reasonable. My screw on the Aiken is sitting out just a little bit. I think the correction is still good, but that could be an irritant down the road. And then my lateral view here, which I think is nothing too egregious. So that's the case. I think I think the thing that I took away, the first thing, and I think you made this point online, was if you're going to start this, or if you're going to be working with a surgeon that's starting doing it, provide ample opportunities for learning. And so whether it's a time or two in the cadaver lab, getting hands on saw bones is helpful. And then I would say, for me, the thing that's probably been one of the more helpful things is, as I get into some of these cases, is spending some time drawing it out where I want things to end up, and just drawing it out preoperatively of what doing some good case planning. And I think that can be super helpful for anybody that's getting involved, and even for if you're the rep that's on the case, just drawing out where you think things should end up on the X-rays just gives you just another sense of what things should look like as you get into things. What are your thoughts, Jan?
Yeah, 100% agree with everything you just said. And I would add also just having using a call a friend option, discussing the case pre-op, even post-op, having like a debriefing after the case to discuss like, hey, I had issues with getting the sesamoid rotation, because like I've learned, sometimes you go and you maybe watch a surgeon do something, or, webinars, talks, and so forth. But then after you do it yourself, going back again, maybe to the lab, or talking to your, mentor, your friend, your buddy, I think can be very helpful in terms of just kind of, regrouping and reanalyzing, pros and cons of, how you acted on that case.
Yeah, I think that's right. I think doing the debrief is so helpful, and then just it's like anything we do, we want to kind of go back and rehash it and make sure what we're doing is up to speed, and when you can do that with your rep, I think is really helpful, at least for me, to kind of rehash it, and then we can go back and say, hey, well, what about what if you use this K-wire instead, or if we approached it, you can approach it this way. I think is super helpful. So
I would agree. So the rep here is very, essential many times, I think, to kind of, provide even some feedback and suggestions, because they've probably seen multiple surgeons, do this, and maybe certain areas where they've struggled, or other instruments that they've used. For example, you mentioned a bailout, right, where you pin it using a K-wire. I think that's like essential. If the rep can be like, okay, hey, metatarsal fractured, instead of, just being like, okay, hey, I've seen this done before. I've seen them sometimes pin it. It's not ideal, but at least kind of giving some options to the surgeon, I think, can be very helpful, because a lot of times in that heat of the moment, we forget things. So helpful hints like that, I think, are critical, and that's where a lot of the value of the reps come in as well. It's not just, hey, here's a screw, right? I mean, anybody can open a screw, but it's that experience, as you know, seeing multiple cases and seeing how other surgeons have dealt with things, can be priceless at that time.
The one of the things that I really liked that Oliver talked about was paying attention to the tone of the burr. And I think when you're doing the osteotomy, especially for this one, it's usually pretty quick. But you know, if you take a calcaneal osteotomy, it can take a little bit of more time. It can be 5-10 minutes, especially if the bone is good. And so listening and paying attention to what the tone of the burr is can be really helpful, because you can start to hear when it feels like it's bearing down and you're getting some bone in there and it's not cutting as well. And we talked about the risk of necrosis to the bone and trying to use cooled irrigation, all these things. But one of the other things is making sure that, you know, when you're in the back table or you're behind there, you can't really see what's going on. You can actually hear a lot. And if you are listening, paying attention to those very subtle things, you'll pick things up, because as you said, you get kind of caught up in, you know, doing the osteotomy, that sometimes little subtle changes like that you may not pick up. And if somebody else says, hey, it sounds like that burr isn't cutting as well, do you want to clean the flutes? That can be a really great verbal cue, because even just yesterday I was doing one and I would take it out, and every little bit I would clean the bone out of the burr and make sure that it was still cutting, and it made all the difference in the world. But you can hear the difference, and paying attention during that time is so critical. It's easy to get lulled into just thinking, okay, I'm just waiting for this osteotomy to be done.
No, that's for sure, right? It you know, orthopedics is an active sport, and everybody's involved in the entire room. So,
All right. Well, thanks so much for everybody checking this out. We'll announce what our next topic is and release the date here soon. And looking forward to catching you on the next one.
all right, thanks, Nick. See you, everybody.
See ya.